In this chapter, let's learn about laboratory tests for diabetes. For diagnosis, we need to test fasting glucose. Fasting is defined as no caloric intake for at least 8 hours. Sometimes we need to know OGTT with 2-hour value or random glucose to diagnose diabetes. We always need to test HbA1c. It can be used as a standard for diagnosing diabetes in the United States. However, it is not currently used for diagnosis in China, and it's most commonly used to assess blood glucose control. HbA1c level reflects average glycemia over previous 3 months or longer. In non-diabetics, this test should be performed at least twice yearly in stable patients and more frequently when therapy changes or patients are not meeting glycemic goals. HbA1c alone does not provide a measure of glycemic variability or hypoglycemia and is affected by the presence of hemoglobin variants, hemolysis, or blood loss. Some patients need to test serum insulin and C-peptide level to know their islets function. Measurement of autoantibodies such as GAD65 and tyrosine phosphatase IA2 are useful in suspected immune-mediated type 1 diabetes. Next, let's learn more about OGTT and the synchronized islet function. We often measure the OGTT at 5 time points, which are before taking sugar, 30 minutes, 60 minutes, 120 minutes, and 180 minutes after taking sugar. The curve marked by the square is the glucose tolerance curve of a normal person. We can see that the peak of blood sugar in normal people is 30 minutes to 60 minutes after taking sugar, and blood sugar drops to the baseline level at 180 minutes. The curve of the circular mark is IGT patients, and it can be seen that the blood sugar level rises slightly after taking sugar. The triangle mark curve is for diabetic patients. Blood sugar is significantly increased, and the blood sugar peak is delayed to the 60 minutes to 120 minutes after taking sugar. Next, we look at the insulin secretion curve. The curve marked by a square is the insulin secretion curve of a normal person. The insulin secretion curve is consistent with the blood glucose secretion curve. The insulin peak is 30 minutes to 60 minutes after taking sugar, and the insulin level drops to the baseline level at 180 minutes. The circular mark is the insulin secretion curve of IGT patients. The insulin level is obviously increased, and the secretion peak is delayed. In the triangle mark curve of the diabetic population, we can see that the peak of insulin secretion is delayed to 120 minutes, and the level of insulin secretion decreases relatively. At 180 minutes, the insulin has not fallen back to the baseline. Therefore, in some people with early diabetes or IGT, due to the delayed peak of insulin secretion and the 180 minutes blood glucose and insulin levels do not match at this time, hypoglycemia before the next meal often occurs. Next, we also need to do some laboratory tests on the patient's complications. Screening for diabetic nephropathy should be done at diagnosis and then yearly for type 2 diabetes, and 5 years after diagnosis, then yearly in type 1 diabetes. 18% of type 1 diabetes may have early kidney changes, and future guidelines may change screening to 1 year after diagnosis if poorly controlled, then annually for both type 1 and type 2. Screening can be performed using an albumin-creatinine ratio, also called microalbumin, in a random spot urine collection. The urine albumin to creatinine ratio is independently associated with mortality at all levels of eGFR in older adults with diabetes. The diagnosis of microalbuminuria, ACR between 30 to 100 to 299 milligram per 24 hours, should be based on 2 to 3 elevated levels with a 3 to 6 months period because there is a marked variability in day-to-day albumin excretion. Patients with overt microalbuminuria, that is, albumin to creatinine ratio over 300, should be followed by urine protein creatinine ratio. A fasting serum lipid panel, serum creatinine, and electrolytes should be obtained yearly on all adult patients with diabetes. Self-monitoring of blood glucose, referred as SMBG, is crucial for assessing the effectiveness of the management plan. The frequency and timing of SMBG varies with the needs and goals of each patient. In most patients with type 1 and pregnant women taking insulin, SMBG is recommended at least 3 times per day. In patients with type 2 diabetes not on insulin, recommendations are unclear for SMBG, but testing once or twice per day is acceptable in most patients. Glycemic control is best evaluated when SMBG is combined with HbA1c testing. Continuous glucose monitoring, CGM, is now starting to play a more prominent role in reducing the number of finger sticks. Dexcom CGM has been approved by FDA for use by patients to adjust insulin based on CGM readings. The use of insulin pump and the CGM readings and computer software can adjust the insulin automatically, known as the artificial pancreas. CGM can also be used in patients with type 2 on multiple daily injections. Limitations of CGM are that it cannot predict accuracy of blood glucose when less than 3.9 millimole per liter. Okay, in this chapter, we have learned the laboratory test of diabetes. Thank you very much.